Hi, everyone. My name is Dr. May Cho. I am a GI medical oncologist at UC Irvine. It is my pleasure to have a discussion with my team and my fearless patients. So let me start by introducing everyone. We'll start with our patient advocate, Ali. Ali?
Hi, I'm Allie, and I have had the pleasure of working with these fine women for the last almost 2 years, and I feel growing pains as I'm going into my second year, and I am 1 year cancer-free.
Great. And we'll go to Alana. Alana, please.
Hi, I'm Alana. I'm a nurse practitioner at the UC Davis Cancer Center. And at the time Allie was being treated, Dr. Cho was here at UC Davis. And so we were all the team together that worked with Allie through her treatment and in ongoing surveillance.
All right. Not last, not but least, our amazing case manager, Melissa, please.
Hi, my name is Melissa. I'm one of the nurse case managers at the UC Davis Cancer Center, and I had the pleasure of working with Dr. Cho, Alana, and of course, Allie as well.
Rather than we're presenting, how to treat and take care of stage 2 and 3 colorectal cancer patient, we thought that taking Ali Jane with us, chronological order, it would be a lot more interesting and useful in the real-time clinic setting. So let's start with Ali, like how you present and how you were diagnosed, and what's your initial emotion about this diagnosis and how to start that journey.
Okay, well, first, my dad had colon cancer, and I went into my primary doctor, and just for a routine physical, and I said, yeah, I have some blood as on tissue when I'm wiping, and it's about once a week or once a month, sometimes twice. But I thought it really was an old hemorrhoid that was just showing its face again. And so she had me go for a colonoscopy, and I was 17, as she put it, I was 17 years late in getting a colonoscopy. When I first heard during the colonoscopy at the very end, I saw the cancer. The doctor said, we don't know yet, we have to do a biopsy, but I saw it. So I could not be a doubting Thomas. I saw it with my own eyes. I was prepared. So when they called to say, Allie, the first thing he said was, Allie, it's curable. So right there, that was the best thing and the best way to present it. I knew I had cancer. I knew it was going to be cured. I wasn't fearful. But as I came into meeting the surgeon and what was going to be taking place, and I realized that I wouldn't be able to travel. And that was the hardest thing. So for me, I didn't cry and I wasn't upset that I had cancer. I was brokenhearted that I was not going to be able to travel and go to my DNA conferences and do my genealogy research as much as I had been doing. So that was hard. And so I cried the first time I had to click cancel on a conference. So
So I guess if it would have been in COVID time, you would not have that. You would not feel that. Right?
Exactly. It would have hit us hard. Exactly. And so I had my 1 year basically pre-COVID. And I'm sorry for the rest of you because this is the way I live. So welcome to my party.
Okay, so when I first saw Ali, I have some colonoscopy report and MRI report, which is very important to really diagnose the rectal cancer patients. And then what we found is Ali, rectal cancer is pretty low. We call it low lying tumor, which is very close to the sphincter. So patient who has very low lying tumor or like patients who are lymph node positive, we are starting to treat with what we call total neoadjuvant therapy, which we gave chemotherapy for 4 months to really get the response. And then we go into the chemoradiation, and then we go into the surgery. So I explained it to Ali that the first step will be the chemotherapy for 4 months, which is the chemotherapy consists of 5FU, which is the pump that she has to carry for 2 days, and then oxaliplatin, which we give it every 2 weeks. From that, I'm gonna let Melissa to take over how she helped all these coordinations to start the chemotherapy.
So yes, whenever I have a patient that I know is going to be starting on the FOLFOX regimen, which includes the oxaliplatin and the fluorouracil 5FU, where they'll need to be attached to that pump for a period of time, initially we need to set up for port placement. So a lot of times when I'm first meeting someone in Ally's situation where they're initially diagnosed, I like to go over what that process is and what to expect. I've found that usually imaging, as far as showing somebody what a diagram of what the port looks like is really helpful. And then just explaining what it's like to be connected to the pump, because that really throws people off up front, even though that may not be the most pertinent thing right at that moment. I like to touch on it just because people really seem to feel uncomfortable with this great unknown of this port being placed in their body and then not understanding how they're going to be attached to something for that period of time. So I do go over that. And of course, the chemotherapy teaching, we give patients a chemotherapy resource binder. And in those binders, we include chemotherapy information handouts on the specific drugs in the regimen that they're going to be receiving. Once the patient is going to be scheduled for their chemotherapy, I then like to do a treatment plan which outlines, how often they're getting that treatment, how long it's going to be, the home medications that should be going home, and they can bring those in at their first initial treatment, as well as a calendar so they know how often to get their labs done, and so forth. So the calendar part comes in later. Definitely, I like to tell people up front that it's in stages. So we address things as they start to come, because it's overwhelming in that initial visit after they've talked with Dr. Cho to piece all of this together right away. So those are the initial things, is kind of talking about the port, and then letting them know we're going to go over this treatment plan as things gets closer, the home medications as it gets closer, and then eventually the calendar as things start falling into place.
Okay. Then Alana would take over the patient's care, and then really like take care of, before each chemo visit. So Alana, would you like to take over how you help manage chemo symptom and
Yeah.
emotional support at the same time?
Yeah. So, there is some variation. Sometimes I see a patient before their first cycle. Sometimes it's not until after their first cycle, depending on how quickly they're getting going. Regardless of whether it's before or after their first cycle, I definitely find we know that cancer is an overwhelming diagnosis. We know that we give patients a lot of information to absorb. So even though Dr. Cho's gone over the plan and Melissa's done a great chemo teach, I'm basically doing more of the same usually in that first visit or two, reviewing the diagnosis and the plan, getting a really good baseline for where the patient is. Are they currently having bleeding with their bowel movements or per rectum? Or, what are their bowel movements like now? What's their energy and appetite like now? So I have a good baseline. And really, that first visit is always longer just because patients usually still are really trying to process and digest and get their head around what's going on. On a kind of cycle by cycle basis, I really make a point of then checking on the patient's energy, their appetite, how much cold sensitivity they're having, because that is a very common side effect of oxaliplatin. It's one that they're almost guaranteed to have, but there's a lot of variation. Some patients just have very faint cold sensitivity in the fingertips and, you know, for a day, and others have really severe cold sensitivity in their hands, their mouth, that lasts for many days. And really the only way to manage that is to avoid cold, you know, wear gloves, not drink and eat cold things, which can be challenging, especially here in Sacramento in the summertime. The other things I always check on every visit are nausea and vomiting, and then bowel movements. Even though diarrhea and constipation are possible side effects of the FOLFOX, FOLFOX isn't really a big offender in this regard, but of course anyone with a colorectal diagnosis, we want to make sure that we keep those bowel movements moving and that they are soft and not having a lot of diarrhea. And then later cycles is when I start to focus more on whether they're starting to have any peripheral neuropathy and mouth sores. And as far as managing those, I do at the beginning kind of do some anticipatory guidance, because the best thing for not getting mouth sores is to prevent them. So really good oral care. They can do a rinse with just a simple solution of salt and baking soda, which you're probably, many of you are already familiar with, but that can really help, along with just, you know, good oral hygiene. And then same thing with hand-foot syndrome. The thing is to prevent it. So good moisturization, lots of regular application of lotion. I encourage patients to put lotion next to their bathroom sink or kitchen sink, wherever they wash their hands, and use it whenever they wash their hands. And then, of course, we're always following labs. And I know in Ally's case, she did have some neutropenia, and we had to get her started on a growth factor support. That's not common on this regimen, but it is something that can happen. So, and then of course, reviewing, you know, just use of the nausea medications. We typically recommend people just kind of do them proactively for 3 days after chemo, and then as needed after that. But again, you'll find lots of variation in how much nausea people experience with the regimen.
It's great. So, you know, Ali finished the 4 months of FOLFOX. So the next step is she has to go into the chemotherapy with the radiation. So she then went and saw the Dr. Monjaza, who is our radiation oncologist. We keep seeing Ali because we, you know, there's a chemo component in it. For that chemo component, sometimes we do the pump, sometimes we do the pill called Xeloda. So I'll let Melissa take over, like, you know, how she helped with this, the Xeloda pill coordination with the radiations and, you know, even support for like IV fluid in case patients have diarrhea from the radiation.
So usually if a patient's going on Xeloda, they've already typically been familiar with being on some form of chemotherapy beforehand. I will still provide the Xeloda handout, or Dr. Cho has already. Typically the patient has already been to our chemotherapy class, so they're familiar with you know, common side effects and how to manage things and who to reach out to when they need support or have any symptom related issues. But when Xeloda is ordered, it's an oral therapy. So I initially need to get our specialty pharmacy involved because they are key in talking with our patients about these specialty oral medications. They review with the patient and do a consultation about what to expect, how to take it, what do you do if you miss a dose, those types of things. And they're also instrumental in facilitating the authorization with the patient's insurance. So they're really key. So I usually start with that. And then I have to piece together with radiation oncology to see when they can get the patient in and then when they anticipate a treatment start date, because that needs to correlate with when we get that Xeloda in hand for the patient. So there's a lot of behind the scenes communication going on. And then of course, making sure that the patient has had all of that come together by the date that we're anticipating starting the treatment. And I usually try to do a calendar at that point for the patient once we know that date as well.
Yeah. One thing I wanted to also emphasize is that, our radiation oncologists will educate that too. Our goal in particular in Ally case, and, especially with this patients these days, younger patients are getting the rectal cancer. Our goal is not only to cure the patient and to have a full, functional life after the cure. So one of the radiation side effects from the rectal cancer is the vaginal stenosis. So we kind of educate to use the vaginal dilator, so then to prevent that, for the chronic side effect. So and I'll let Alana to explain how she followed during the chemoradiations part. Alana?
So just to say, even before chemo radiation, right, we, as Melissa was alluding to, we really want to minimize a treatment break between the chemo and then the start of chemo radiation. So in those last cycles of chemo alone, I'm already looking ahead to make sure that the patient's getting teed up for radiation, that the Xeloda has been ordered so that everything can be synced. And then, as far as side effects go, patients are already familiar with the possible side effects of mouth sores and hand-foot syndrome from the pump, but the vast majority of patients haven't really experienced those side effects from the FOLFOX. They're much more likely to with the Xeloda because they're taking that pill 5 days a week. So it's good to, even if you've talked about it before, to really re-emphasize the importance of, again, moisturizing with regular application of lotion and good oral care for the mouth sores. And making sure with the mouth sores that they have that prescription of lidocaine viscous in case they do develop that. And then the other thing I always do during the chemo radiation is confirm that they're taking the Xeloda correctly. We have an amazing pharmacy team and they call, but I feel like this is something, because they're only taking it the days with radiation, like definitely multiple points of reinforcement is a benefit. And then, as May said, we have a great radiation oncology team, and they also were doing their own education. But again, we are asking a lot of the patients. This is a lot to manage. So multiple points of re-education and opportunities to reinforce, I think, really does help the patient move through this process. So even though we're the medical oncologists, I do also, at the start of the radiation oncology, just really like to give some anticipatory guidance about what to expect with the radiation, because I feel that those first few courses of radiation, the patient doesn't really feel anything. They go lay on this table, they hear people pushing buttons, and they don't feel much. But then it really escalates. And, I use the sunburn analogy of, it just adds on. So the anticipatory guidance there. And then at some point, probably about the middle of the course, they're very likely to start having some pain, and they are very likely to start having diarrhea, especially as in Ally's case, where it's a lower rectal tumor. So usually the pain can be managed with just low dose opioids, such as Norco. maybe once or twice a day. Some patients need a little more. I have had patients that, using the Norco around the clock, I then also put on a long acting for the duration of the chemo radiation and, until they've healed afterwards. The other thing is early on, even going back to before we're setting this up, is to get an IV therapy plan in place so that you have authorization, so that if the patient is, comes in and they've really been having a lot of diarrhea and they haven't yet gotten used to controlling it with the antidiarrheals, that you can get them some IV hydration without having to wait for auth. So those are the main things that I focus on in a regular chemo radiation visit. The vaginal stenosis is in there, but to be honest, at this point, most people are focused on getting through treatment, and I really circle back to the vaginal stenosis more during the surveillance visits.
So, Ali, I'm sorry to like make you relive that radiation part. So if you can just give some wisdom about, what to watch out for the patients, and then, what are the things that help, that would be great.
Okay. Yeah, I had very low rectal cancer. So my diarrhea started about probably the beginning of the third week, if I'm remembering correctly. And it went to being controlled. I had, as it went on, it was like, as soon as you felt it, you had to get to the toilet because you had absolutely no control. It's kind of like, I guess when you're younger, if you stepped out in the cold weather or you sneeze, now as older, you have no control. So that was learning your own body was really important to what's going on. I didn't have pain until I'd say that last, I think I had 3 treatments, had a Thursday and a Friday, and Friday night is when I really had painful diarrhea. And it was, it was like a blowtorch. It was burning, did not describe how bad it was. And what I would recommend is that as a patient gets closer to the end of their treatment and they are not on any kind of Norco or whatever pain medicine, that pain medicine is a prescription's given, even if it's just a minimum of 4 or 5 pills to get them through a weekend. In my case, it happened on a Friday night, pharmacies are closed, and I was not in a state of mind. I know Dr. Cho said, Allie, why didn't you call the emergency number? We give you a number. It was not in my thought process. And so that Monday when I came in, if that Monday was not my last treatment, I would have said I quit. If I would have had to go through a whole week of that, I would have said I quit. One of the techs told me, Allie, you're going to have some really, he did say burning diarrhea. And he says that pain's going to last you 10 to 14 days after treatment. And then Alana and I, we talked about that. And I think we talked, and she called me right before going on vacation. I said, hey, I'm okay today. And she was good. Maybe it's short-lived. I had 2 days of no pain. And right after about, I think on that Friday again, I'm allergic to weekends because that Friday I had painful diarrhea through the weekend. I mean, it was just, my body's crazy. It doesn't react like normal to me, but not for others. So yeah, radiation was very hard.
Yeah. So, yeah, we've been trying to be proactive with giving the, pain medications, and then, this lidocaine cream for the pain,
Mm-hmm.
kind of even the beginning of the radiation. So
Yeah.
to
Can I offer one more thing too?
Mhm.
About midway through, I was asking the doctor, and I said, okay, now exactly where is the radiation going? Is it pinpointing? And he said, no, it goes across your body. Now, understand, it's me you're talking to. So across my body, and it says, take care of your skin. I'm thinking, okay, I have tattoos on either side of my hip, and then one at my tailbone. So it's going across that area, and I'm not seeing any tanning going on. So I asked the nurse, exactly where am I supposed to see? She goes, well, you ask the tech. So it just happened the tech that was getting me on the table that day was brand new. And she said, well, why do you want to know? And I said, because I want to take care of my skin. I have no itching, but I'm looking for wherever this tan is supposed to take place. So she said, okay, it's from your tailbone straight down. If they would just tell you up front, because of where the radiation is going, it's going to hit your crotch area. Then you would know exactly what you're looking for. And let's face it, you can't look, you got to take a mirror and look. It's not accessible without a mirror. So, that I would, it's the doctor, the nurses, and the techs, they cannot be embarrassed more than the patient. So whatever they can give for, up front, helps us through and takes away that embarrassment.
That's great. So, after radiation, the next step is to do the surgery. For rectal cancer, we wanted to make sure there's no complications. So after the surgery is done, we have to have the ostomy, for at least for
Mhm.
like 6 to 8 weeks. So we only have like 3 minutes left. So I wanted to quickly give to Melissa how you help the patient with the ostomy care, because it's a little bit involved, and it is a new lifestyle for the patient. So
Mhm.
Our colorectal surgery team is really wonderful. They have a nurse navigator. They also have an ostomy nurse. So usually I just need to beforehand make sure I see that the patient is plugged in with that team, and has been able to go over what the plan is for surgery, what to expect, and do the educating. After the surgery, what I look for is making sure I review the hospital notes, because that nurse that sees the patient in the hospital does a full assessment. And that's how I usually can be guided as to what the patient has been able to understand and demonstrate, what supplies have been ordered. And once a patient is discharged, there is sometimes a break in those supplies getting to the patient, and the home health nurse getting out to the patient. And that can be really distressing. So really making sure that patients are getting seen appropriately, and that once they get home, that they have that support that they need. Once I speak to a patient after I know they've had an ostomy, assessing the stoma, because there can be swelling. Is there any bleeding? Making sure that they are getting more comfortable with changing their bag. How often are they changing their bag? What does the skin look like? So all of those things, and it's I can't say enough how distressing it can be for people to adjust to this new period. So just trying to provide that emotional support too. I had one patient that it was as simple as, I can't handle the smell. It wasn't even the change in body image. It was the odor. And sure enough, we just had never thought before about ordering a deodorizer. And after that, she was much more comfortable, and then felt like she could handle doing the learning. And but it takes time. So so those are the primary things. Definitely the nurses in the clinic reach out to our ostomy nurse very often when we need help with additional issues from there.
okay, Alana, you have 30 seconds. We always say the patient, they are at least time for 5 years with us, right? So can you go over the surveillance plan?
Yeah, so I mean, I think in that short amount of time, what I'll say is we do follow the NCCN guidelines, but I think what's really important to note is that this is a very significant transition for the patient. Some patients are really excited to be done with treatment and move on. Others are very anxious because this is, they've kind of marshaled for the fight, and now the fight is done. And so now sometimes this transition brings up their anxiety. So just to really offer a lot of support and reassure them that we are still their team. and that they're still our patient.
Okay. All right. Let's wrap with Ali. You have maybe another 30 seconds. What can you tell the patient? How do you change in terms of lifestyle modification, after the ostomy reverse, and, how are you living your life?
Oh, I'm doing everything that the government lets me do at this point. I still can't travel. Learning the body all over. I feel so good. I told you, I forget to take my Metamucil. So it's like, putting everything out. As when I finish cleaning up the kitchen, I put my stuff out for the next meal, and I start with my Metamucil so I don't forget it. I have my own emergency pack that it stays with me. So if we're ever somewhere, I always have Metamucil and a bottle of water. So I love not having an ostomy. So it still has its own drawbacks because you have to really be prepared, and you have to know your body. You have to know those little signals that you need to get to the toilet. So, but I'm happy, and I love all of you. And I'm going to put a little plug in for Dr. Hallaby, best surgeon ever, not because of his skill, but because of his humanitarian. And he treated me emotionally and got me to I was not nervous at all for the surgery.
Great. Thank you so much, everyone. I always say, taking care of GI cancer patient, it take a village, and it is the tough road, but with the help of each other, including the patient itself, we can conquer this.
Yes.
With that, we'll conclude this session.